Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OBGYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me, separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. In today's episode, we're going to talk all about PGT-A, which is pre-implantation genetic testing, more specifically for aneuploidy, where we biopsy the outer cells of the embryos to determine if they are chromosomally normal or abnormal. We're going to discuss the benefits and limitations of this test, as well as the controversy surrounding transferring mosaic embryos, and primarily controversial because there are a lot of clinics out there that just don't transfer these embryos. We're also going to discuss whether or not there's a clinical setting where you would consider transferring a chromosomally abnormal embryo and whether or not that would result in a healthy ongoing pregnancy and possibly live birth. Today, I have Meaghan Doyle, who is a certified genetic counselor specializing in fertility genetics and the founder of DNA Genetic Counseling. She obtained her undergraduate degree in genetics and psychology at the University of Toronto, which is my hometown, and her Master of Science in genetic counseling from Arcadia University. She started her fertility genetics career as a genetic counselor in a fertility clinic and soon realized that not many clinics have an in-house genetic counselor. She founded DNA Genetic Counseling to help make fertility genetic counselors more accessible to patients and clinicians across North America, aiming to have less conflict of interest since she's not affiliated with a particular IVF clinic or genetics lab. Meaghan focuses her work on pre-implantation genetic testing, or PGT, mosaicism, and aneuploidy in embryos, and the genetic causes behind infertility and IVF failure. She is passionate about helping fertility patients by providing them with evidence-based information they can understand and ensuring they are fully supported to make decisions that will be best for them and their families. Meaghan also enjoys educating about fertility genetics on Instagram, where she shares her experiences working as a fertility genetic counselor with a chronic illness. It's so good to be here. Thank you so much for taking the time to come and talk to us about this. I think it's a really important and exciting topic, something that, for me personally, patients are constantly asking me about. There are many times where we do have to send out to a genetic counselor because, we don't have an in-house genetic counselor. So having a resource like you is just so valuable.
Absolutely. And something that I think patients really appreciate, having the opportunity to talk to somebody in more detail about a lot of these.
So to start, why don't we sort of get into what is PGT and why it's done?
So PGT-A specifically is looking at a test that's done on embryos that have been created through IVF. And the goal is to help prioritize embryos for transfer. So there's a lot of nuances that we'll get into, but we're trying to identify the embryos that have the highest chance of leading to an ongoing pregnancy. So highest chance of implanting into the uterus, lowest chance of leading to a miscarriage. And we can screen for a small number of genetic conditions.
Yes, that's exactly how I counsel my patients about it, because I think there's a lot of misunderstanding about genetically testing the embryos that you are selecting, the healthy ones, which sometimes we'll say to make it easy. But then I think patients understand that as, well,
I really try to avoid the use of the word healthy because we're really not testing for the health of the child that will be born. I think that's a common misconception. It's really about, does this embryo have a chance at leading to a baby? Not really about the health of that baby once they're here.
Yes. And while we're on the topic of discussing what PGT is, and more specifically PGT, can you talk about the different types of PGT and what their indications are?
Yeah, so mostly when people hear about PGT from their doctor, we're talking about PGT-A, as you mentioned, and the A is for aneuploidy. That is a chromosome difference. That is a extra chromosome, missing chromosome, a large piece of the chromosome that's missing or extra. And as we said, it's expected to impact the embryo's chance of leading to birth. That's available for anybody who's going to be doing IVF as long as they're offers that. It's not right for everybody, but it is available for everybody. The other types of PGT are mostly for people who are going to be predisposed to having something because of their family history or something that's been identified on a genetic test already. So that would be PGT-SR. R stands for structural rearrangements. That would be where someone has done a test called a karyotype, which is looked at their own chromosomes. We've learned that they are predisposed to making embryos with rearrangements in their own chromosomes. We can specifically look for the genetic differences in their embryos to know what's different in their genetics first. Then there's PGT-M. The M is for monogenic conditions. If you're doing something called carrier screening before, where we're looking to see if you and your partner are at risk of having a child with a genetic condition, or if you have a specific genetic condition yourself, we can design a test for the embryo to test for that specific condition, learn which embryos are not expected to have it, and then you can prioritize the embryos who have. So those are the three main types.
Yes, and PGT-A use has grown exponentially. I think that many practices just sort of do it on absolutely everybody, which will lead me to my next question. I was hoping you can elaborate more on the difference between genetic carrier screening and pre-implantation genetic testing, because I think there's so much confusion out there about them being the same thing, and patients thinking that their embryos were tested for a particular disease when that wasn't the case at all.
Yeah, absolutely. Carrier screening and PGT-A are doing two completely separate things. Carrier screening is about once you have a baby in your arms, is that baby going to be at an increased chance of having a genetic condition that's going to impact their health? PGT-A is about, will this specific embryo be able to lead to a baby or not? It's not at all about that health of that child. So if you've done carrier screening, it's not really telling us at all about if you can or can't have a baby, if your embryos will work. And if you've done PGT-A, it's not at all telling us if that embryo is going to lead to a healthy child. So two completely separate tests. If you've done one, it doesn't mean you don't need it.
Right. Yes, I love that. And I think everybody should do genetic carrier screening before having a baby because, why not get that information? So I want to sort of segue back to what the indications for PGT-A are, because especially in the United States, most clinics are sort of doing it on everybody. There's only smaller practices that I'm seeing where they don't really push for the patient to do PGT. It's not part of any package. If there's that added expense to do this test, a lot of people opt out. But if it's included in the cost of treatment, then everybody wants to get it done. So what would you say as a genetic counselor would really be a person to strongly consider doing PGT-A?
I think what I really appreciate about my job is that it lets me spend more time with the person so I can get to know them better and tailor the guidance to them specifically.
I love that.
A lot of the time when they're meeting with their doctor, there are so many things to talk about and there's only a little bit of time to spend on PGT-A.
Yes.
And sometimes when people are getting educated about PGT-A, it's often in a group setting, sometimes by the laboratory that may be selling the test. So there isn't a lot of opportunity for the really nuanced discussion about, is this test going to be right for me? When I'm meeting with a patient before they're doing PGT-A, we can really break it down, talk about the pros and cons. A lot of the time, the factors that we're considering are their goals. What are they hoping to accomplish long-term with their family planning? But we're also taking into account the age of the egg provider. A lot of the research that's been done, and PGT-A in general is conflicting about how useful it is. But when the studies are showing that it is helpful, it's usually helpful for providers who are over 38 or over 40. We know that aneuploid is more common as our eggs get older. So if we're screening for aneuploid, it often makes sense that we're doing with people who are more prone to their embryos showing these chasing results. But I also consider how many embryos are you expecting to get, and would you want to transfer those embryos regardless? There are some people who would want to transfer all embryos, and a lot of the time clinics are not going to allow you to transfer an embryo with an aneuploid result, and they don't realize that until after they have their PGT results in hand.
Yes.
And then they're in this really tough spot of having a result for an embryo and now they can't use that embryo, but they want to. So I think it's really important to think about your goals and your clinic's policies before you opt into PGT-A, and making sure that your goals and your preferences are aligning with your clinic's policies as well.
Yeah, I love that. And you're right. A lot of people don't realize that they can't transfer an aneuploid. There are particular clinics like where I work, it's at the physician discretion. For me personally, I'm all about patient autonomy and whatever they want to transfer, as long as they have the information necessary and they've seen a genetic counselor and know the possible outcomes. There are a lot of benefits to PGT-A. Can you touch on that?
One of the things that a lot of people appreciate is that if you have an embryo with a whole chromosome aneuploid, there's a lot of nuances with specific results, but there's one specific type where the chance of that embryo leading to a birth is incredibly low. By being able to identify those embryos, you're going to be able to avoid transferring them. If we didn't have those results, you'd be going in a little more blind. Especially as we age, it's going to be a larger proportion of your embryos that are expected to have those results. Doing PGT-A lets you find that normal embryo and prioritize it for transfer. The benefit of PGT-A is speeding up the time to pregnancy, because you're not wasting time with transfers of embryos that aren't expected to work. So you kind of open the genetic information, you know the embryo that has the highest chance, and you prioritize that, and it can possibly help you get pregnant faster. You can proceed to another IVF cycle if none of the embryos are normal, without going through transfers of embryos that aren't expected to be successful.
Yeah, and I think that that's something many people don't realize. And for the listeners who don't understand what is involved with preparing for a transfer, most often this will be a separate cycle. So after you've had your retrieval, 2 weeks later, on average, you will get your period. And then with the start of this new menstrual cycle, we start preparing for the transfer. You might have a mock cycle before then, which delays the transfer an extra month or so, maybe more if you need additional treatment. And then you go to transfer an embryo and it doesn't work. Or even worse, it leads to a pregnancy loss. And the further along you get, not only are you more attached to that pregnancy, and not only is there the physical consequence of having to deal with a miscarriage, now you've lost all this time of potentially doing, who knows, maybe 2 more retrievals to potentially get to that chromosomally normal embryo that will more likely lead to pregnancy. So what would you say is the biggest limitation of PGT?
That's a tough one. I think that it's honestly a lack of understanding of the nuances of the result types. I think that, we could talk about validation of the PGT labs and how a lot of them are different, and that there's no standardization between the laboratories and how they're regulated. But I think a lot of that can be handled by more broad understanding and awareness for patients and clinicians about the nuances of the kind of gray area of result types.
What would be considered gray area?
That would be what we call a mosaic result, a segmental result, and even a no result. It isn't just normal or abnormal. If you are told your embryos are abnormal, you need more information, because it's not as clear cut as that.
As a clinician, one of my biggest fears is we now know that most early embryos are mosaic to some degree. And so is the area of biopsy the part that's potentially chromosomally abnormal and being reported as aneuploid when it's really a mosaic that can potentially, people talk about self-correcting and lead to a successful pregnancy. And my fear sometimes is, are we discarding normal embryos when we're reporting aneuploid? And what's your take on that?
I think it depends on exactly what we're seeing on the aneuploid result, because there's really a few different subtypes of the aneuploid. So are we seeing just a piece of a chromosome that's missing, or what we call a mental aneuploid, or are we seeing a whole copy of a chromosome that's missing, a whole chromosome aneuploid? Whole chromosome aneuploidies are usually present in the entire embryo. When we've done research, a lot of the time the entire embryo has them. There are no normal cells. Not all the time, nothing is nothing's ever 100% or 0% in medicine. But if we get that result type, there's probably a very low chance of an ongoing pregnancy. But if it's just a piece of your chromosome, there is a chance that that embryo could have normal cells and could lead to a healthy live birth. Knowing your subtypes of aneuploid results can help you. It's probably not going to be your first choice for your embryo transfer of any aneuploid. For some people, it might be. Everybody is different. Everyone's bringing different things to their decisions. That's why I appreciate working with clinicians who are pro-patient autonomy, because everyone is kind of bringing different things to the table when making these decisions. And some aneuploids do have a chance of leading to a healthy live birth.
I love that. I remember the first time listening to you say that, and I thought, yeah, oh my God, this is the first time I'm actually hearing a genetic counselor say this out loud, that there are some aneuploids that we could potentially use and transfer. In my clinical experience, so far, 100% of the mosaic embryos I've transferred have led to live births, which is wild. It's so strange. And in some cases, it was the only one left because the euploid embryos were not successful, which always leads you to think, well, you know, obviously, we're assuming that 5 to 8 cells that were biopsied is giving us the entire picture of that embryo when there is, you know, hundreds of cells and we don't even know what their genetic makeup looks like. So I think that it's optimistic to think that we can know just from a few cells what the entire embryo really its genetic makeup is. But with mosaic embryos, you know, since there were studies ongoing showing that this could actually tell me live births, I immediately sort of jumped on that and was like, oh my God, we got to transfer these embryos.
Absolutely.
So do you mind explaining what a mosaic embryo is?
So when we get a mosaic result on PGT-A, it has suggested that the sample we took, which is usually like 5 to 10 cells, that some of them were normal cells and some of them were abnormal cells. We never know what the rest of the embryo looks like, but from that sample, some was normal and some is abnormal. And so mosaic embryos, there's been a lot of research done now, and even within the category of a mosaic result, there are subtypes. I often spend a whole hour with somebody just helping them understand what is your subtype, what do all of these different little kind of predictive factors mean, what's the risk for the baby that might be born. But there are so many healthy babies out there born from mosaic embryos, and so I think that a lot of people leave genetic counseling appointment talking about mosaic embryos and feeling more hopeful, because it can be hard seeing a report that doesn't say normal about your embryo.
Absolutely. And sometimes I actually will get patients leaving their practice because they don't want to transfer the mosaic that they have left. I think that's always a shame when they're not willing to do that because of whatever that they have in place. I think it's very promising. The other thing I also talk about with patients is that when it comes to the PGT-A results, oftentimes with the mosaic reports, what we're really looking at is the copy number of chromosomes. From my understanding, it's averaged out from the cells that were tested. And I think that's a difficult concept to understand. So how do you explain that to patients?
Visual aids. I am such a visual learner. I do a lot of my appointments via Zoom and have pictures to explain everything. So I usually have an example of what data is generated from a PGT test, and I have a picture of what a mosaic result looks like. You're exactly right. It's just kind of, we call it intermediate copy number, which doesn't mean a lot. When we do PGT-A, they're not testing the cells one at a time and opening up each cell and saying, okay, this cell was normal, this cell wasn't, this cell is normal, this cell wasn't. They're opening all of them up and taking the DNA out, putting it in a sample together in one big clump and testing it in a big aggregate sample. So they don't know how many cells were normal and how many cells weren't. They know kind of like what percentage of the sample was normal compared to a baseline. And that's a lot of the time how we talk about a low-level mosaic. That's a result where it was kind of closer to normal. A high-level mosaic, the results were closer to abnormal, but there were still a lot of wiggle room in there, and visually it's helped a lot.
Yeah, I think the visuals definitely help. I think if you even try to explain the graph that you see for the person interpreting the result, it's sort of like this literal graph of 2, 3, 1, and there's a squiggly line that hopefully is at 2, but if it's sort of in between 1 and 2, then are some of the cells missing this chromosome? And so that's usually what leads to that report. But I also tell patients all the time that there's the possibility of artifact and misinterpretation from the person reading it. It's not as objective as we think it should be.
That's right. I think labs are getting better at using things like AI and technology, so there's less room for human error, but sometimes they do both because humans are important in this process. But we're hopefully starting to add on more technologies so that we can be more confident in mosaic results. There can be things like contamination or just so many things in the testing process that sometimes can make an embryo look like it has a mosaic result when it's actually completely normal or completely abnormal. That's why some mosaic embryos don't work at all. Some mosaic embryos do lead to miscarriage, but a lot of mosaic embryos lead to healthy babies. And so these are all things we talk about. There are kind of clues in results where I walk through patients all of these details when we're talking about their specific embryo.
I love that you really try to get to know the patient to see what route for them to take, whether or not to do PGT-A. I have had patients, even older patients, who said, no matter what, I want to transfer all of my embryos, so why would I test? And for those patients, I'm like, absolutely, you shouldn't test, because if we're going to transfer them all, let's just let the body decide. And as long as they understand some of the risks involved with that, particularly if above 40, that's really reasonable to do. And I know that this is really dry for some of the listeners, especially if you're not super interested in basic sciences. But I think it is important to understand the different ways that labs do PGT-A. So what are the different techniques of genetic testing? Are we testing the whole genome? What are they doing to figure out the number of chromosomes? I know that whole genome sequencing is a whole different discussion, but that's been emerging. I would love to get your take on the different ways that the labs are doing genetic testing to give you a result.
So there's two main technologies being used today for PGT-A. There is next generation sequencing, what we call NGS, and then there's SNP testing. Some labs use both. Some mostly use one, and some mostly use the other. Next generation sequencing is certainly the most popular. That produces graph. Both produce graphs. But next generation sequencing is the one that really brought mosaic results to the forefront. But what I'm seeing a little bit more of is labs adding on this SNP technology to help make the results a little bit more accurate, reduce the chance that they're getting contamination in their results that they can't detect, or being able to add on the ability to test for extra types of genetic conditions. But sometimes labs just use SNP testing, which does make it harder to detect mosaicism. But sometimes what they can do is they can get a cheek swab from both of the reproductive partners, and that way they can do an extra level of testing where they can determine, did the genetic changes come from the egg provider or the sperm provider, which is fascinating. Sometimes we can get a sense of that from the type of chromosome difference. If it didn't come directly from the egg or sperm provider, it might be embryonic, which could be mosaic. Regardless of the technology, sometimes there are ways of adding on extra techniques. You can get to the bottom of where things are more likely to be mosaic.
And I love the ability to detect, whether it's egg or sperm, because I think we always just tend to blame the egg no matter what.
Today, I want to talk to you about a tool I personally recommend to my patients who are trying to conceive, Aneuploid. Aneuploid is the first at-home fertility monitor that tracks 4 key hormones: estrogen, LH, FSH, and PDG, using a single, easy test strip. In just 10 minutes, it gives you incredibly accurate hormone readings, but without the stress of lab visits. Aneuploid can help you detect your fertile window with precision, predict ovulation reliably, and confirm ovulation has occurred, giving you a complete understanding of your cycle. This comprehensive hormone tracking becomes particularly critical when we consider anovulation, which is the leading cause of infertility and often goes undetected. Aneuploid serves as an indispensable tool here, not just for predicting ovulation, but more crucially for confirming it. It achieves this through a sustained rise in PDG, the urine metabolite of progesterone. As a physician, I trust the data Aneuploid provides. I use it to monitor how my patients are responding to treatment, and I can adjust their plans in real time based on actual hormone levels. So if you're looking to take control of your fertility with clarity and confidence, I highly recommend Aneuploid. Head over to Inito.com and use my code TTC Podcast to get your starter pack for just $89. That's INITO.com.
Mosaic embryos. We're both aligned on transferring mosaic embryos. How do you work with clinics that are not allowing the transfer of mosaic embryos after you've counseled their patients because their patients found you on their own? Now they feel really motivated to transfer a mosaic embryo.
I have sometimes been successful in having clinics change their policies. Some of my patients have been the very first patients at their clinic to transfer an embryo with a mosaic result. It has been a combination of the patient's self-advocacy, and sometimes my consultation notes are quite thorough and contain a lot of the evidence around mosaic results. I think sometimes people are outdated in realizing how much evidence we have that there is a low risk to the newborn from embryos and mosaic results. Sometimes it's just institutional policy and those things take time. Sometimes physicians have individual control and there can be shifts when a patient wants to advocate in that way, but sometimes things move slowly and the patient doesn't necessarily want to wait. I do have some strategies where they can move to a different clinic. It's unfortunate when a patient needs to do that because it takes time, it takes money, it's frustrating, relatively safe. You would know more about the risks involved in that than I would. You would always rather the embryos stay where they are, but I've had patients move their embryos.
Yeah.
That has success afterwards.
And I've had patients do it also internationally. So the companies are really great. Now there's new companies where in some cases you can have an embryologist transport the embryos, an extra level of safety because they're always the ones that know how to troubleshoot the tanks if there were to be an issue. The transportation bit, I think, is pretty good. I have had embryos transported from Asia, from the Middle East. So it has been successful in that sense. We can definitely do it, but it like you said, it really sucks to have to do that because of the time involved. I usually tell my patients, you should allocate an extra 3-ish months, depending on where it's coming from. And then, like you said, the additional cost in some practices will charge a high administrative fee to accept their embryos, which is a massive inconvenience. And this is where I do think that getting yourself informed prior to even going into an IVF cycle is really key. Doing your homework because like you said before, even a 1-hour consultation or follow-up to discuss the IVF process, which personally, I think I take more time than a lot of my colleagues do. I still don't think it's enough time. There's just too much to go over. Everybody wants to know the details of the evaluation, what this ovarian stimulation cycle looks like, what preparing for transfer looks like, how we evaluate the uterine cavity. And there's just so much to discuss. And you're usually discussing with someone who has no baseline knowledge of sometimes even the menstrual cycle.
Right.
So it's just so much overwhelming information that outsourcing to a genetic counselor to describe all of these additional tests prior to making embryos is really valuable.
Yeah, that's a lot to talk about in an hour. I spent an hour talking just about PGT-A.
Yeah.
So there you go.
And arguably, that may not even be enough for some people.
Yeah.
So I'm sort of flip-flopping and getting back to the different forms of testing techniques. We talked about next-gen sequencing and SNP. Now there's emerging testing out there that arguably is maybe not as validated for whole genome sequencing for the embryos. What is your take on that?
I am not a huge fan on a lot of this testing. As you mentioned, I don't think it's especially validated. There's different labs doing different things. So some are looking at diseases. They're trying to find embryos that are maybe predisposed to certain conditions, what we call polygenic risk scores. So which embryos have a higher risk of things like coronary heart disease, type 2 diabetes, the list goes on. Then there are other groups trying to assess embryos that may have brand new genetic changes that may be impacting the embryo's ability to lead to a pregnancy and assessing those things on a whole genome level. There's a lot that is evolving in the embryo space. The whole genome is generally all of our genetic information. There's a lot that can be done there, but there are still a lot of limitations in that space. And everybody is looking at different things with different goals. trials. And I think we've already seen that there are significant limitations of PGT-A where we designed a test and didn't understand all of the nuances before it was available to patients. And now we're still understanding all the repercussions. I think that happens in medicine, but especially in genetics, is that tests are designed and we almost do the research with patients clinically rather than in a research setting where we figure them out and then they become available to patients. And so that's my concern, is that something will sound really good and people will pay a lot of money for it. And then we will start to realize the consequences of that afterwards, as it's already been available to patients for a lot of years. And so I think it needs to be important that we approach things cautiously, hopefully with genetic counselors involved, so that there is limited information.
I'm always feeling really torn about this because I love innovation because it is what got us here in the first place. And I know that even in the beginning of clinically attempting to do IVF, back in the day, it was super controversial. A lot of people were against it, creating a test tube baby, so to speak. And it was the persistence of these scientists, doctors, that led to IVF being as successful as it now is. I'm always kind of torn about new testing that comes out. I think in a perfect world, we would have clinical trials where patients would not be paying out of pocket for these things in order to gain more information, but I know that that isn't really the world we live in at this point in time. And I also understand the patients wanting that extra information and saying, well, I can do whatever I want with my money, so I'm not going to wait for something where I'm going to get to enter, for instance, a clinical trial and get this covered. So yeah, I always just sort of feel torn about how do we balance innovation with safety and appropriate counseling. And I think that just setting expectations of our knowledge is limited.
Yeah, I agree. And I think a good approach, again, is to speak with somebody who isn't affiliated with the laboratories.
Yes.
So speak with your doctor, of course, and then if you can speak to an independent genetic counselor, I think that's a good strategy. Certainly people from the laboratory may know the most about the product. And I think that's a challenge that I experienced too with some of these newer companies, is that there's not a ton of transparency. So as somebody independent and as somebody, sometimes hard for me to gain a lot of information about it so that I can counsel. So that always raises a little bit of a red flag for me. And then I would be transparent with patients about that as well. But I think the further removed we can get from the person selling the product or the test when you're trying to make that informed decision, the better, because there will hopefully be less biases.
That's super important. So speaking of which, and I know that you have no conflict of interest, which is great. So, but I also understand, want to name specific names, but from your perspective, would you say that there are labs that are significantly more trustworthy than others? And I'm sure some listeners would want to know exactly what those companies are, but I'm just curious to get your point of view.
From a standpoint, I definitely do have my preferred labs, and I will tell my patients those labs. I prefer not to say them on a podcast, because things can change. I do tell my patients my preferences, but what I usually look for are the labs that are continually testing their test. Sometimes a laboratory validates their test to a minimum standard, and that's where they leave it. Other laboratories are continually researching their test and improving it. I like to see that they may be doing things like a blinded non-selection trial to see if an embryo has an aneuploid result. Let's mask all of the PGT results and transfer embryos and just see what actually happens clinically with all of these results. And
I love that.
I just think that's the ideal way to do things.
Yeah.
Not everybody thinks that is ethical, but there are patients that would agree to that.
Right.
And if we can do that, let's see if aneuploid embryos actually don't lead to babies, and let's gather that data. Laboratories that do that are certainly mine preferred. If we can't do that for all result types, let's see if we can do it for some. Also, laboratories that are going to follow up on adverse outcomes openly. So if you have a euploid embryo that results in a miscarriage, will they offer something like products of conception testing, where we test the miscarriage tissue? Are they openly going to investigate a prenatal test that's abnormal? If they seem to feel like that is a worthwhile effort, that's a green flag for me. If not, it feels like they feel like adverse outcomes are a bad thing that they're trying to hide. This is not a perfect test. I feel like they should be acknowledging that and openly investigating why things go wrong. It's not necessarily gone wrong, it's just part of human biology.
And that's every aspect of medicine where not all of our tests are perfect and they can be incorrect. Even in the most validated cases, it can still be incorrect. And I think that doing inspection for quality assurance to make sure that there's something from a technical standpoint that could be improved or something about a specific test that needs to be changed. In your experience, since you work with so many different labs and you get to see the outcomes, do you feel that certain labs have higher pregnancy rates in live births because their reporting is more accurate?
I think so. And I think it's because of the technologies that are used and the technologies that are choosing to be used. There's an interesting study done where they compared 4 laboratories on individuals. They looked at the rates of euploid results and the rates of live birth. And there was significant differences between the 4 laboratories.
Yes, I remember that study.
So obviously there are differences, and that was in a young age group where we'd expect there to be not a lot of differences. And anyway, there seems to be differences between the laboratories. I think that's really important.
I kind of wish there was more standardization between the labs so that, let's say somebody's going to a clinic and they have their preferred lab. I do tell patients at the end of the day, you should have the choice to select the lab where you want to do the testing. Unfortunately, I think sometimes the financial aspect is what dictates what lab they choose, whether it's an in-house lab versus sending out. I guess I'm curious because you're in Canada. Even though I'm Canadian, I never practiced medicine in Canada. Are the PGT-A labs used typically a send out as it is usually in the US, or do a lot of practices have in-house labs?
It's mostly send-outs to PGT labs that are based in the US. Some labs that you're familiar with in the US may have like a Canadian lab. So they're kind of international and they have kind of a hub in Canada.
Yeah.
There's maybe a clinic or 2 that has PGT labs. So quite similar, but a lot of the same laboratories that US patients are familiar with, Canadian patients are familiar with as well.
Got it. So, I mean, ultimately, it's really interesting to see that things people should really consider is meeting with a genetic counselor before doing IVF, understanding the nuances of the possible PGT results, knowing the different types or the different ways that the testing is done in the labs, whether or not it's validated, and asking these questions, possibly even understanding what the pregnancy and live birth rate is based on their reporting. It's all really helpful and useful information to have. What is your thought, though, on doing PGT-A for the sake of recurrent pregnancy loss? And I know that that's a really specific question, but I think that from the doctor's side, we tend to recommend it a lot. So from your perspective, what is your thought on that? Technically, per the American Society of Reproductive Medicine, it's not an indication, but what is actually happening clinically is totally different.
I agree. I think in the Canadian guidelines, it's not an indication as well. I think the challenge is that the more losses an individual has, the less likely it is to be aneuploid that is the cause. I think that's the concern a lot of the time, is that if we are assuming these losses are because of aneuploid and they're not, PGT-A isn't necessarily going to help.
Yeah.
So I think that's an important conversation. If you have had losses and confirmed with genetic testing on miscarriage tissue that they were chromosomal, then maybe you are motivated to do PGT-A because of that. Or sometimes individuals recognize that if they're going through an expensive treatment to prevent their recurrent losses, if there's an immune therapy or something specific that they're doing, it's an added benefit to know that the embryo you're using has a higher chance of working because you ruled out the aneuploid, and you would hate to have that be a contributing factor. So sometimes it's just reassurance that you've done that testing as well. Feel like it's been sold to them as the solution, and then they realize that that's not the case.
Right.
So I think it's an important discussion compared to expected management. For some people, it's not necessarily going to be their answer. And, Is IVF the answer? If IVF is needed, it's a helpful piece. If you'd rather not do IVF at all, saying you have to do IVF, there is not necessarily.
One of the biggest limitations in that setting is with the prior losses, most of the time, patients have not done product of conception testing. So for listeners who don't understand what that is, the tissue from the miscarriage can be sent out for genetic testing to see if it was due to chromosomal abnormality, which is generally the most common cause of pregnancy loss. If you have that information, you have a concrete answer as to why you had that loss. Without that testing, it's kind of a question mark. And then if you have subsequent losses and there's no testing there, then it's really a big question mark as to why you have these recurrent losses. But if every time there's product of conception testing and we know that it's due to aneuploidy, then that paints a totally different picture. And what I've experienced too is having, for instance, a patient has 2 losses and on the third one, they finally do POC testing and it comes back aneuploid. And so we assume, okay, well, this is likely related to aneuploidy. Let's do IVF PGT-A, and then it does not work. We transfer euploid embryos, and it just keeps leading to pregnancy losses. At that point, I'm like, maybe that was just 1 out of 3, and that didn't really explain much. It's really hard to say when you don't have the full picture of why that previous loss happened or losses happened. I appreciate your insight on that, though, because without that specific information, it's not necessarily the answer for everybody.
I'm a big advocate for POC testing. I think there are a lot of people that don't see its value. If you've had your first loss, most people are going to have 1 loss and leave their family the average person's experience. But in the work that we do, we see people who never knew about POC testing until they wish they had known sooner.
Yes.
And so I'm one of those people screaming about POC testing from the rooftops because I think that more people should know that it exists, because I think too often, sure, 50 to 60% of early losses are because of chromosomes. That's still a huge piece that are not because of chromosomes. And I think that we are too often blaming chromosomes or assuming that that's what it is and doing it as sort of when you don't know. So if we can have on paper evidence that it is, then that's great. And if we can see that it wasn't, then that's important as well. If we have the opportunity to get that answer, then let's get it and not continue to make assumptions.
What would be your main takeaways when it comes to PGT and your main 3 points, recommendations that you tell patients?
My first recommendation is get your PGT report from your clinic. There is a lot of information when you're getting your result that isn't often communicated, because when you get results back, it's emotional, especially if you didn't get the results you were expecting. They may have told you things that you didn't retain, or they just didn't have time to explain, or it wasn't the right moment. So get a copy of your report so that you can be informed about what your results actually say. Are there embryos there that you may consider for transfer? Abnormal is not a type of result. It could mean mosaic, a type of aneuploid that might be able to lead to a live birth. It could mean there was no result, and that can also lead to a live birth. So if you're told an embryo is abnormal, not viable, ask more questions.
Yes.
And get a copy of that report so you can talk to somebody else.
I hate the word viable. I'm just like, what does that even mean? You know? Meaghan, thank you so much for all of this information. You explained everything so well and make it easy to understand. So I hope a lot of people really benefited from this talk. Can you just tell listeners where they can find you?
Absolutely, yeah. I'm at dnaide.com, DNAIDE.com. You can book with myself or any of the other genetic counselors on my team. We see patients across Canada and in select US states, depending where we're licensed. Everything is virtual, so we can do phone or Zoom, which is great. We can often see you urgently if you need to. I know things are sometimes time sensitive in the fertility world. Check out our Instagram, DNAIDGC, where there's lots of information mostly about PGT-A, but on other topics as well. If you're interested in my life as a fertility genetic counselor with a chronic illness, I'm at Meaghan Doyle GC.
Thank you so much
For having me. This is great.